Thank you to you and Joe for inviting me to speak, and thanks very much for coming along. Um, I am honored to be asked to speak. Joe has given me the unenviable task of trying to cover a number of topics, which I'm going to try to do. I might run over time a little bit, um, but the topics which I was asked to talk about were one is about exercise, two was about pain management, three was managing dystonia and Parkinson's. Four is a bit on research, and then lastly, medication and potential side effects. Now, I'm not sure I'm going to be able to cover all of them in great detail. So again, if there's questions that I haven't covered, I'm sorry. And if you want to ask questions in the chat box, I'll try and cover things as best we can. I'm going to try and start with the last topic, actually, maybe because it's probably the one that sets up the scene for all the other bits and pieces the best. Um, a talk on treatments in general, I suppose, would be 40 minutes on its own. So I'm going to just very briefly cover um, what I think are important aspects to know about in people who have early onset Parkinson's disease, really for everybody with Parkinson's disease, but particularly for people who may be younger, because I think there may be still some misinformation out there about ways to treat or the best ways to treat. Um, Basically, we have um, quite a few different medications for treating Parkinson's disease. It's fair to say that the main medication that we use to treat Parkinson's disease is levodopa, usually in combination with another drug. The most common of these is Sinemet, which is levodopa and carbidopa. And the role of the carbidopa is actually to stop the levodopa being broken down and actually to cause less nausea, so it makes more effective and fewer side effects. Um, but there are other medications, and the next biggest group to talk about really are these dopamine receptor agonists down here. So things like mirapexin, Requip, Nupro, and apomorphine, which are the brand names for these drugs here. Um, so what levodopa it's what we call a precursor of dopamine. So dopamine is a chemical which is deficient or reduced in Parkinson's. And when levodopa enters the body, it's broken down actually into dopamine itself, and it works on your brain in exactly the same way as the dopamine that was there at higher levels before people had Parkinson's disease. What the dopamine agonists are is they look to your brain like dopamine, but they're not actually dopamine themselves. Because they look similar, it's a chemical that looks similar, they stick to the same receptors and activate the brain in the same way, but slightly differently. And that's why there's some differences in maybe side effect profiles between those two groups of medications. The other drugs, so things such as what are called monoamine oxidase inhibitors, so rasagiline, Rasalect, selegiline, Rendipril, safinamide, are medications which basically make levodopa work a little bit better. It's largely through reducing how dopamine is broken down. And this works on its own because everybody with Parkinson's still has their own dopamine. And similarly with these COMT inhibitors, they can make levodopa work more effectively or for longer periods of time. And there's reasons why we might want to use medications. I'll talk about them later on. The bottom two medications, there's a group of medications called anticholinergics, which are largely used to treat tremor in Parkinson's disease. And they are used not infrequently in people who have tremor who are younger, largely because people who are older can sometimes get side effects with these, including things like confusion and hallucinations. But they're generally well tolerated by people who are younger and can be quite effective for tremor. And then the last one is amantadine, which has an anti-Parkinson's effect, but it's predominantly used to reduce dyskinesias in Parkinson's disease. And I've listed some of the side effects of this from a paper on the side here, but I'm not going to talk about every side effect of all these medications in detail. I'm going to talk a little bit about firstly, the important point that these drugs are symptomatic, which means that the role of them is to treat the symptoms of Parkinson's on the days that they're taken. They're not directly neuroprotective, which means they don't slow down or stop the progression of Parkinson's disease, except for the fact that when Parkinson's disease is well controlled, people tend to do more things. They tend to exercise more, they tend to stimulate their brains more, they tend to socialize more because they're physically much better. And as a result, they tend to do more things, which has a protective effect on your brain. So those activities are important for people's brain health. Um, when we tend to treat things or change treatments, we don't usually make changes in the treatments based on seeing somebody in clinic and saying, you look like your Parkinson's is under control, and as a result, you need more medications. We tend to treat, at least I do anyway, tend to treat based on what the person is telling me. So if they feel that they're a bit more slow, or their medications are wearing off a bit faster, or they're not quite doing the things that they were able to do a year or two ago, that's usually the trigger to suggest somebody might need more medications. Very occasionally, I will say to somebody, I think you'll feel better if we try a little more medications. But generally speaking, it's not a sense that on my side of the table, I say, you need more medications. As a result, you have to take more, basically. So it tends to be tracking people's symptoms rather than how people look. And often takes a bit of time and a good enough dose of medications before we say that things don't work. So certain things like tremor, for example, which is the last point there, on small or medium doses of medications, tremor may not respond. And sometimes people need very high doses of medications for their tremor to respond. So sometimes it takes a little bit of patience and trialing things in order to get the best treatment options for people. This is a slide I show a lot, and it's important to explain some of the things that people are often concerned about when they're newly diagnosed with Parkinson's, because they've heard about things like dyskinesias, or what we call motor fluctuations in Parkinson's. And this slide kind of explains, at least it makes sense to me, how this thing tracks over time. And there's no number of years on the bottom, but levodopa is a short-acting medication, and we tend to start off people taking it 2 or usually 3 times a day. And most people, but not all, when they start taking the medications, find that from the moment they take their first tablet in the morning to the moment they go to bed at night, they don't really appreciate any ups and downs of the medications, even though the blood levels of those medications are going up and down during the day, which is why it needs to be taken 3 times a day. The brain just isn't sensitive to that up and down fluctuation at the early stages of Parkinson's disease. But what can happen over time, and for many people after a number of years, and that could be 5, 10, or 15 years, or shorter or longer, suddenly these ups and downs in the medication doses are sensed by the brain, and you can feel medications wearing off. And when the medications reach a peak, people can experience dyskinesias, which are these extra movements, and I'll show a video of them later on, for people who aren't familiar with them. And this can be a bit of a problem, because people get used to feeling that medications are working well and suddenly feel like they're not working well. And that is usually initially in a predictable fashion. So 30 minutes before the next dose is due, people can feel a little bit of a dip, and it takes another 15 or 20 minutes for that next dose to kick in. But you add up all those 30 and 15-minute periods throughout the day, and it can be a significant portion of time. As Parkinson's ticks on over time, this window, the sweet spot, really can narrow, and there can be sort of a smaller period of the day where things are good or things are on all the time. People can oscillate between having bad dyskinesias and very quickly wearing off, and they take another dose. That dose doesn't quite kick in because it doesn't get them into the green area, so they have to wait for the next dose to kick in, etc. And then all of a sudden they experience dyskinesias, and this can be quite a rocky road. Not all people with Parkinson's experience it, and it can take a long time for people to get to this point. But it's important that people understand some of the things when we talk about these fluctuations, why they occur, and they can be a significant problem for people. So I talked a little about this. So the 2 main things to talk about are dyskinesias, which are these extra movements that happen usually at the peak of dose, but can happen also at the bottom of the dose. Wearing off, which is usually at the end of the dose or in the early morning or nighttime, because if people are taking regular medications throughout the day and not taking tablets when they're asleep at night, first thing in the morning, people can feel very stiff and slow, can find it takes them a bit of time to get going. And that's often, for most people's journey with Parkinson's disease, all they'll experience. Rare people do experience much more severe fluctuations, which is when we have to think about, more complicated therapies and treatments for Parkinson's, where people can sort of, we call it yo-yoing, people go from on and off and on and off, doses don't work. And a thing called super offs, which is extremely rare, but when people are doing perfectly fine and literally like a light switch, things can switch off. And it's not common for that to happen. For most people, it's a slightly easier on and off that just involves usually tweaking of medications in order to get things under control. This is a very old video, but the reason I showed it is that it's sort of a good sort of average demonstration of what dyskinesias are like. You can see that this man's head is turned to the right. He's got some pursing of his lips a little bit, and you can see there's a little bit of rocking of his shoulders as well.
Okay.
And for most
Good.
people who
Now
experience this,
Even on the floor, can you do this?
it's not usually that bothersome. Now, it can be much more severe than this and can be extremely bothersome. And it can be even milder than this as well, that people barely
Is it the
notice
same
it.
as the other side now?
When these occur, and the reason people may stress about it is it can be socially embarrassing. People can get to this point in their Parkinson's journey without anyone knowing that they've got Parkinson's disease. And all of a sudden, there are these movements that become worsened by stress, so social situations happen at the time when your Parkinson's medications are actually working well for you, that you're not often stiff and slow. And so it can be a problem for some people. But in general, unless it's bothering somebody, we don't need to address this
Yeah, take it
particularly.
now.
You can see this man's his left arm is going behind his back a little bit. That's not a mannerism. That's actually his dyskinesia that's causing his arm to go behind. And
Once more.
the only two situations which you say this should be treated is one, if it's interfering with balance, because if they're severe, it can throw people's balance off. And two, if people are losing weight, because if you think about it, if you're doing even minor exercise all the time, all day, every day, you can lose weight. And we don't like people with Parkinson's losing weight. So that's the reason that we say these need to be intervened. But if they're bothersome, there are things that we can do to address them. The other thing to say is that we talk about these things as their motor fluctuations. And when we talk about the ups and downs, we're constantly talking about dyskinesias or stiffness and slowness. But it's important to say, as many people probably know, there are lots of what we call non-motor symptoms of Parkinson's disease. So bladder problems, difficulties with sweating, blood pressures going up and down, sexual dysfunction, dry eyes, stomach problems, including constipation, nausea, dribbling or drooling, and difficulties with swallowing, pain, tingling. Many people with Parkinson's don't experience many of these, but they can be part of people's Parkinson's. And the reason I'm putting up all of these things, including depression, anxiety, impulse control disorders that I'll talk about later on, sleep disturbances, is because many of these actually fluctuate with the Parkinson's medications. And the ones in red are ones that particularly can become much worse when the Parkinson's medications dip. So many people don't feel that they get stiff and slow, but they might feel, for example, that they get a little sense of panic, or they might feel very tired, or they might feel that they get some pain when they wear off. But if you looked at the person, you wouldn't notice any difference. And it's important to acknowledge that the ones highlighted in red can represent what we call non-motor wearing off. Sometimes these fluctuations can come without any change in the physical appearance or the physical symptoms of somebody. But so there are things that we can do to address these. So, for example, if these start creeping up, if wearing off is the main problem, we can add in some of those medications that make things last a little bit longer. If these dyskinesia are a problem, we can add on a medication that suppress the dyskinesia. Sometimes we spread the medication doses out more evenly throughout the day, so the amplitude of the ups and downs are less severe, and it's sort of a smoother curve throughout the day, but that can be a little bit annoying to take medications frequently throughout the day. But there's lots of ways to address these with just adjustments in tablets. The reason I'm talking about this at such length is because that up till about 10 years ago, for people with early onset Parkinson's disease, there was the concern that once you start levodopa, that there's a clock that's now ticking. At some point, that person will develop motor fluctuations, and that if you were to delay, if somebody is, say, 48 and is diagnosed with Parkinson's disease, that maybe we should delay starting levodopa for as long as we can until we have to, and at that point start levodopa. And then if they're 60 at that stage, well, then maybe we won't get motor fluctuations for another 15 years, and that might be okay for that person. So what used to happen, and still does to a certain extent, is that people are started off on dopamine agonists, so things like mirapexin and Requip, etc., to manage Parkinson's disease at the early stage. So that's a very valid approach, actually, and it's probably as good as starting levodopa for many people. But the idea of sparing levodopa may not be necessary, and it might not necessarily be the best thing for a few reasons. This study was done about 10 years ago, and what they did was they looked at people in Ghana and who didn't have access to levodopa, and they compared those people when levodopa became available to a group in Italy. This was a study run in Italy, and what they showed was that the people in Africa, basically, once they started levodopa, because there was a huge run-in from the time that they were diagnosed to starting levodopa, and when they started levodopa, almost immediately they started developing motor fluctuations, compared to the Italian group who started levodopa years before and, roughly speaking, developed motor fluctuations around the same time. And this was a groundbreaking study, because what it really told people was that the main driver of the development of these motor fluctuations is actually the disease ticking on over time, not necessarily the time that you start levodopa, although perhaps the amount of levodopa that people are on might drive things a little bit faster. And certainly, um, there's the feeling that if people never start levodopa, they may never get these motor fluctuations, but it's sometimes tricky to manage Parkinson's for a lifetime of somebody with Parkinson's without using levodopa at some point. The other thing to say is that we are increasingly aware of these impulse control problems or impulse control disorder issues that are a little more common with the dopamine agonists, but can also be caused by other medications such as levodopa and amantadine, and are actually probably a certain amount of it is inherently part of Parkinson's disease and is worsened by medications. But it's felt that maybe up to about 20% of people who take dopamine agonists can experience some of these problems, including gambling, shopping, hypersexuality, eating, overeating, and we often watch out for these things because they can be very problematic if they're severe. And there's maybe a sense that we're a little bit more nervous about using dopamine agonists than we were before. So there might be a shift back now to using levodopa earlier, using less of dopamine agonists. But when we do it, they work quite well in combination. And sometimes a little bit of one and a little bit of another is quite a useful way to manage Parkinson's disease. So basically, this levodopa sparing approach, as they call it, really doesn't have a long-term benefit. And actually holding off treatment full stop is actually definitely detrimental. So if people don't start medication for years because they don't want to start on medications too early, that negatively impacts their prognosis. As I said, we are a little bit more cautious about using dopamine agonists, but don't avoid them. And I said a combined approach might be the best way to do things. We often manage things with medications, but sometimes these motor fluctuations can become severe, and that's why we have things like pump therapies and surgeries like deep brain stimulation, which I'm not going to talk about today. But when things can't be managed, we have lots of other options available to us, many of which are extremely effective. So now I'm going to move on and talk about exercise, because it's kind of an area of interest of mine. And a few years ago, there was this idea emerged that maybe we should be talking about exercise in a prescribing way, that we should say you need to exercise X number of hours a week in order to manage and control your Parkinson's disease. And this has come through lots of research that has actually come through. I like research or I like information and data. So I'm going to talk a lot about some of the studies that have been done. But it's very clear that exercise is very good for essentially every organ in your body. And exercise encompasses things like aerobic exercise, strength and conditioning, flexibility and balance. All of those come under the umbrella of exercise. And the World Health Organization is now interested in exercise, saying that we should, for brain health. And it says that people should be aiming for maybe 150 minutes, which is 2.5 hours of moderate exercise, or 75 minutes of vigorous exercise a week in order to promote their brain health. This is for everybody in the world. They're defined what that is based on amounts of calories you burn compared to rest. And we know that people with Parkinson's disease exercise less than their age-matched controls. So somebody who has Parkinson's disease might exercise on average about 30% less than somebody who doesn't have Parkinson's disease. So back in the early 90s, the first sort of evidence came out that perhaps exercise might even protect people from getting Parkinson's disease or developing Parkinson's. And this was a study done in Harvard that basically showed when people who did university athletics were less likely to develop Parkinson's over their lifetime than people who didn't. But most of the evidence that's come has actually come from animal studies, and we do a lot of animal studies in medicine, and it's not always a good way to study a disease in humans by looking at a disease in animals. But it's sort of hard to argue that putting rats on a treadmill isn't a good way to study exercise. And what they showed in a very early study was that high intensity exercise had protective properties in rats that were lesioned. And what lesion means is that they inject a chemical into their brain to stop those cells producing dopamine. So it's like Parkinson's, but not quite the same as Parkinson's. But it showed that basically they had what were called neuroprotective properties, which means that their brain was more protected with exercise, and that their motor function was also better in those patients or the rats who were exercising. And so they looked at this in lots of different ways. So you can exercise rats, and then give them the chemical which can reduce their dopamine levels. And in those rats, their motor function was better, and they preserved their own dopamine neurons, the nerves in their brain which produce dopamine. They preserved them more with exercise before the injection of the chemical. The other way to look at it is to inject the chemical, if you like, simulate Parkinson's, and then start them exercising. And even in that setting, which is a much more realistic thing for somebody who has Parkinson's, the amount of dopamine that was transmitted through the brain increased, the breakdown of dopamine reduced, and also there was more receptors, so the dopamine could work more effectively. So very clear evidence that certainly from an animal study level that exercise would be protective for people's brains, which is what everyone's trying to do. So the real question is, does this translate to humans? And this is a study where they just got people to do one bout of vigorous exercise, and this is off medications, and this is the parts of the brain that light up when medications are on board for Parkinson's. And exercise activates the same areas of the brain, and this is also associated with improvements in motor scores. And I'll talk about what the UPDRS is later on. But this, a single bout of exercise can have the beneficial effect on movement that a single dose of medications does. Also, this Giselle Petzinger is a scientist from the US. She's done a huge amount of work on showing that actually there's brain, what they call plasticity changes that happen with exercise that are not just overall brain health or people's brain being better, but specific to Parkinson's, specific to dopamine, that there are changes that happen in the brain with exercise. Does it translate into improvements in symptoms? And yes, it does. So bradykinesia, which is the slowness of movement associated with Parkinson's disease, power training and also resistance training can improve slowness of movement in Parkinson's disease. There's been lots of studies looking at gait and balance in Parkinson's, and this is a study which averaged lots of different studies, which is why there's lots of lines here. But basically, the average diamond at the bottom shows that posture instability, which is the ability to stop yourself from falling, improves in the short and long term with exercise. And also the number of falls or the frequency of falls improves in the short term and long term with exercise. And this is just from averaging lots of small studies, which is a very good way to look at whether there's a real benefit for an intervention. It also improves cognition, and there's now good evidence to suggest that exercise can both protect the brain from cognitive decline, but also improve cognition with exercise. And mood also improves with exercise as well, which I think happens is probably not a specific Parkinsonian effect, but also works for everybody. What the last thing to say on exercise is that exercise improves the effectiveness of the drugs that we take. So this is a study where they got half of the people to exercise and take their medications, and the other half just took their medications. And there was a much better response to the medications in the group that exercised along with medication than those who didn't. So it probably makes the drugs work more effectively as well. The real reason that everyone's interested in exercise now is because there's this suggestion or this hint that perhaps exercise may be the only disease-modifying therapy for Parkinson's available at the moment, and maybe the only thing which can slow the progression of Parkinson's disease. This is a study by Grace Crotty, who's a neurologist in Cork now, but this one she was in Boston, and there's been a lot of interest over the last few years in trying to demonstrate that exercise slows down Parkinson's. This is a study where they took 360 people with Parkinson's, and they split them into whether these were people who did, for example, competitive sports or did maybe high intensity exercise throughout their life. And they found that their cognitive test scores slowed less slowly, and their time to reach a certain stage of Parkinson's disease was also slower in the people who exercised. So that's a suggestion that this maybe has an effect, but it's not the best way to study it. The best way to study whether exercise has an effect is to start people exercising and follow them long term. Looking back at whether people exercised in the past is a sort of a flawed way to look at it, but it's sometimes the only way we can look at things when we don't have the information. Largely because these are difficult trials to do. A lot of the drug trials that happen when you give somebody a medication, follow them for a year or two is fine, but it's actually very hard to organize an exercise-based trial where you get people to do lots of the same type of exercise that would get their heart rate up to the same level that shows that this is the exact same exercise in everybody. So it takes it difficult to do, but people have started doing these. Now we don't have a huge amount of the results back yet. But this study from about 6 or 7 years ago looked at the split between doing exercise for more than 2.5 hours a week or less than 2.5 hours a week or not at all, basically. And they showed that regular exercise or people who became regular exercisers throughout the study had a slower rate of decline in a simple walking test where people get up from a chair, walk for 3 meters, turn around and sit down again, which is actually quite a good marker of overall physical ability. People who didn't exercise did less well on that, or progressed at a higher rate. This is another study that showed people with newly diagnosed Parkinson's disease who exercised had less decline in their motor symptoms, their mood and anxiety, and their cognition over that period. So a growing body of evidence to say that this is probably a very good thing for people to be doing. The problem is we have very few, as I said, randomized controlled trials where you basically split a group in two and say, right, half of you exercise, half of you don't. It's very hard to do that. So we don't know, for example, what the best type of exercise is, how frequently you need to do it, how intensive it needs to be, or how long you need to exercise for. The other thing to point out is that not everybody can exercise, and it's not everybody can exercise at a high intensity. People have things like arthritis or heart conditions, etc. So exercise isn't possible for everybody, and certain it's not possible to prescribe a certain amount of exercise for everybody across the board. There's two trials that are ongoing at the moment I'm just going to mention. One is a study looking at treadmill training where this is going to be, I think, reported in the summer. And they looked at high intensity exercise 4 times a week, where they actually aim to get people up to a certain heart rate over a 1 year period. And it's a big number of participants, 370, like it's a proper trial. And those results, I think, are going to be quite important about telling us what needs to be done or how much exercise is needed to optimally control Parkinson's. There's another study looking at cycling. Again, a large number of people enrolled in the trial. Again, an in-home aerobic exercise, trying to get to a certain heart rate for up to a year. So I think they're going to be two really important trials that I think are going to get reported quite soon. But the bottom line is that of the information that we have available at the moment, almost all forms of exercise are beneficial. Dance has good evidence, Tai Chi, Nordic walking. All of these things are actually, I would suggest at the moment, I'd say that anything that people can do to exercise is probably beneficial. There's a hint that maybe aerobic exercise might have the best evidence, but we don't know that for certain yet. So there's a lot of interest in even doing yoga, stretching. All of these things probably have huge benefit for people with Parkinson's disease. Dance is a big thing, and I'm sure there are many people who dance. We took part in a study on Irish set dancing, but Argentinian tango. Lots of different types of dancing are beneficial for Parkinson's in a way that's probably beyond the exercise actually as well. And there may be a rhythmical cueing aspect of dancing as well. I might move to the screen. So there's an interest in what's called dual task training. We did some research in this early on and trying to combine cognitive tasks with exercise. And this forms this what's called exergaming now thing, which people are interested in doing, and might be a very beneficial way for people to stimulate their brains in a cognitive way as well as getting exercise. And it might have more than an additive effect in Parkinson's disease. I'm just going to move on a little bit. So it's not a one size fits all, basically a personalized approach, and acknowledging that not everybody can exercise the same amount is the way to do it. There's been recent publication a few weeks ago about people exercising too much, and there was a case series from London where somebody had lost a huge amount of weight and had become very fatigued because they were exercising for 3 hours a day in addition to doing exercise classes, and another person who was hiking for miles and miles and ended up having to be airlifted out of a mountain because their medications essentially wore off because they were exercising too much. So it's important to highlight, it sounds like I'm saying exercise as much as you can, but you can exercise too much, and there, I've encountered people who might almost exercise too much because there's this sense that maybe this is the best thing they can do for their Parkinson's disease, but it can actually impact your quality of life by just obsessively exercising all the time. So it's important to say that not too much exercise may be a bad thing. So I'm going to move on to pain quickly, and then I'm going to talk about dystonia, which maybe we'll have time to talk about. But pain, we used to say that people with Parkinson's do not experience pain, and that was the thinking. And actually, I think some people probably think that, but actually, pain, as many people probably know, is really common in Parkinson's, and it might be one of the most common symptoms of Parkinson's. And we think that maybe 2/3 of people with Parkinson's experience some degree of pain. It's hard to know whether all of what pain is related directly to Parkinson's and what pain is just caused by other things unrelated to Parkinson's. But either way, the motor problems in Parkinson's irrespective of what the source of the pain is, can probably worsen that pain. So things like dystonia, which we'll talk about in a moment, walking, balance, and posture problems can definitely make pain worse in Parkinson's. And also other things like problems with sleep and mood can also exacerbate pain. So it's important to acknowledge that although pain can be directly part of Parkinson's disease, acknowledging that it's a symptom of Parkinson's or not Parkinson's that can be worsened by Parkinson's itself. But it has historically been really undermanaged and underassessed, and that's probably the medical profession's fault for not really appreciating how much pain can be part of Parkinson's. But it is probably getting better, I think. It's complex because there's a lot of different sources of pain. So we now think of it a little bit like there's probably chronic pain that's related to Parkinson's disease, and then there's unrelated chronic pain. And people have done lots of work on this now, and this is a sort of a heavy going section, but I'm just going to explain some of the different sources of pain. These terms, which you don't need to worry about, are nociceptive, neuropathic, and nociplastic, are now what we feel are three different types of pain that you can experience in Parkinson's. And they can rate the severity and frequency of them. You can actually score total pain scores that are actually important if we're going to start trying to address people's pain and trying to reduce it. A very common source of pain is what's called nociceptive pain, which just means that the pain receptors in your body are feeling pain largely because there's damage or inflammation to some tissues in your body, and they are most frequently bones and joints. At any age, we sort of say if you did an MRI scan of your lower back, the chances that you'll have what are called degenerative changes in your spine are probably your age plus 10%. So if you're 50 years old, 60% of people at 50 will have degenerative changes in their back, which can cause pain. And it's important that people who have arthritic related pain acknowledge that there's probably a separate treatment to those things, although some of that pain can improve with treatment of Parkinson's disease as well. So the classic thing would be, a shoulder pain. A lot of people present with Parkinson's shoulder pain, and that's exacerbated by their stiffness in that arm. So it's often on the side that they experience stiffness, but there's also inflammation, the tendon inflammation, the joints that happens there. Many people experience lower limb pain or leg pain or lower back pain or across the shoulders. And I said it can sometimes be the first sign or the first symptom of Parkinson's disease in some people. The second type of pain is people can get pain in their peripheral nerves. So everyone has all your nerves that come from your brain down your spine and go out to your peripheries, your hands and your feet. They branch like trees, and sometimes the nerve endings can become damaged. That can happen with age, it can happen with diabetes, it can happen with alcohol, and lots of other different things. But it can happen maybe disproportionately in Parkinson's, maybe because there's some maybe vitamin deficiencies which are more common in Parkinson's disease, and particularly B12 and B6, which can cause this type of burning pain, or some people often describe a painful cold sensation or even electric shock-like sensations that can run through their body. If it's mild, it can be experienced as an itching feeling, and a lot of people with Parkinson's can experience an itching, and that probably is a form of neuropathic pain, and that requires different treatments. The last thing to say is that there is pain which is not explained by any of those things. And this is probably the pain that we talk about being inherent to Parkinson's disease. And it often becomes apparent when people's Parkinson's medications wear off, or sometimes when you stop medications. And dopamine agonists are a classic one that people can experience pain that they don't experience in their back or their shoulder. It's not in any particular location, although many people feel it around their stomach. It can be everywhere. It can move around. It cannot be any particular location. This can be really tricky pain to try and understand or diagnose. And this is the type of pain, I think, which was not really appreciated as part of Parkinson's, but almost certainly is. I'll move on. This is a different pain scale. The factors that influence pain, we think it's more common in women. It's probably more common in people who develop Parkinson's at a younger age. It's exacerbated by people who have mood and or anxiety problems. If people's movement symptoms, their motor symptoms are worse, it's usually more problematic. Fluctuations, like I talked about earlier on, can interfere with that. As I said, poor sleep can be a real exacerbator of pain. And it's important to try and address as many of these things that we can, including things like mood and sleep, etc. The treatment, as I said, is often neglected, and I'm sure I have neglected people's pain in clinic. And my opinion on if pain is severe and problematic, it's kind of important that experts in pain are involved in care. And I think that we should probably be involving pain specialists a little more in management of pain in Parkinson's. The problem is that medications for pain can sometimes worsen Parkinson's symptoms, and getting that balance right can be tricky. So we think of pain management as pharmacological, using medications, and non-pharmacological, so approaches that don't use medications. The first thing to do is to see if there's a Parkinson's or a Parkinson's medication related fluctuation in people's pain. So if somebody says, I get pain 30 minutes before my medications are due, and when I take a tablet 15, 20 minutes later, that pain goes away, I know that that is probably related to their Parkinson's, and that sometimes optimizing their Parkinson's medications to smooth those fluctuations out are all that needs to happen. There's been no trials done on this, and again, I said it's a neglected area. But there's a study in China, a study in France, both of which showed that levodopa can help musculoskeletal pain, and also a single dose of medication can lead to up to maybe even a 63% reduction in pain following from overnight withdrawal. So from the morning time, taking the first dose of medication, and then 1 hour later, a huge drop in pain. So that may be, for anyone who experiences pain, maybe the only treatment needed and maybe the best treatment. We often prescribe things like anti-inflammatories, so ibuprofen, diphene, things like that, and to treat pain, because there's always that feeling that most pain is muscular or musculoskeletal, and that's probably a good way to treat it. There have not been good studies on this, and there was a study looking at oxycodone or OxyContin, which is, a strong opioid medication, and it showed that it didn't improve pain and actually caused significant side effects. But there's maybe a small group who got, for example, pain at nighttime that improved from it. I was involved in Canada in a study looking at cannabis oil, which is a thing that people ask about a lot actually for pain, because there's obviously evidence or suggests that maybe it works for people who have MS-related pain, etc. This was done during COVID, and actually it was a very small study, largely because it took a huge amount of time to get the study approved, even though in Canada cannabis was decriminalized. But it suggested that people probably do tolerate medications, and there's a hint that maybe it might improve pain, but it certainly needs some larger studies. There's been lots of surveys of people who use cannabis who find that there's an improvement in their symptoms, but there's been 2 proper trials done that haven't shown improvement in pain. So I think it's kind of clear to say that we don't have enough evidence to suggest that this is a good approach for people to manage pain in Parkinson's disease. The other thing I'll talk about in a few moments is dystonia, and certainly if dystonia can cause pain, and botulinum toxin injections can very dramatically improve that source of pain. I said earlier that a trial looking at oxycodone didn't show any benefit. There was one study which showed duloxetine, which is an antidepressant, but actually primarily it's used for pain, and it was one study which is on 20 patients. These are small studies that showed that there were a marked improvement in pain scales after about 6 weeks of starting on this medication. The other thing to say is that there's now interest. Deep brain stimulation can definitely improve pain in patients who have pain. We don't do deep brain stimulation to treat pain, but if there's other indications for it, we often notice that people's pain tends to improve. But there are non-invasive, and these are largely in a research setting, non-invasive forms of stimulation, where a thing called transcranial magnetic stimulation, where you put a coil over the top of someone's head, hold it down, and it induces a magnetic field which can stimulate nerves and can improve pain in some people. But really, it's largely in a research setting. Let's not forget exercise. There's certainly evidence that exercise can improve people's pain. Yoga, massage, acupuncture, all these things have evidence, but there, I said, haven't really been good clinical trials done on these as well. So just moving on to dystonia. Dystonia is a common early onset Parkinson's symptom. It can happen at any stage in Parkinson's disease or any onset of Parkinson's disease, but it tends to be common and can be the presenting symptom for many people who are young who develop Parkinson's. What dystonia is, it's really continuous or sustained posturing, twisting, spasming, or cramping of muscles that can happen at different times of the day. Dystonia is a condition of itself, and there's people who just have dystonia and that's their condition. Or dystonia can be a symptom of other conditions, and Parkinson's is one of those conditions that people can develop dystonia in. There's lots of different ways the muscles can become postured or cramped, and a common way is for the foot to be turned down and in. That can interfere with walking as well as causing pain. The other one is that the toe can point up, the big toe can point up. We call that a striatal toe, or sometimes the toes can cramp. As I said, it's a hallmark of early onset Parkinson's. Sometimes makes us think about genetic forms of Parkinson's, although most people who experience this do not have a genetic form of Parkinson's. It's usually or most commonly what we call an off phenomenon, which means it happens at the bottom of the dose, so nighttime and early morning when the medications are at their lowest. But it can sometimes happen when medications reach their peak as well, and that becomes a little more tricky to manage. Pain can be significant. So if it's very clear that this is happening as a off phenomenon, we try to just optimize people's medications and get their medications as good as we can get them, because sometimes that's enough. Even giving medications during the night can sometimes help with nocturnal dystonia. There are other medications, but to be honest with you, they don't work that well. And if somebody has troublesome dystonia, there's really only one treatment that we talk about, which is giving botulinum toxin injections. Also, people are often referred to as Botox, although Botox is just one form of botulinum toxin, and there are others. So these are just pictures of people with foot dystonia. And there's evidence to suggest for many years now that people who get painful foot dystonia can get dramatic improvements that is often sustained for many months. But botulinum toxin only really lasts for about 12 weeks or 3 months. So they need repeated injections, maybe 3 or 4 times a year. But pain can vanish completely with it. And certainly if people have problems with foot dystonia, that doesn't just cause pain, but also actually can interfere with walking. People can walk on the side of their foot because it's so twisted in, and you can get dramatic improvements in it. There have been lots of trials now, small trials, not that well conducted, showing sustained benefit in not just pain, but as I said, is in gait analysis and lower limb function. But all of these are small studies, 14 patients. But at this stage, I think we have enough evidence to suggest that this is beneficial, and it's at least worth a try if somebody has dystonia that's problematic. It's also used for other conditions as well as these atypical Parkinsonian symptoms as well. There's lots of muscles in your leg, and sometimes it's trying to find the right muscle that needs to be injected. And I've just a short video here just to show people who haven't seen it or don't know what it's like. It basically involves a very, very small needle that's connected. The little wire connects it to what's called an EMG machine, which measures muscle activity. And an experienced person can find the muscles fairly easily. And there's sometimes a little bit of, if I can use the term, poking around to make sure you're in the right muscle. And the reason the machine is there is to hear that you're in that right muscle. So if the toe is sticking up, you put the needle into the muscle, and then you listen, ask the person to move their toe up and down, and you can hear that muscle activity so that you know that you're in the right location. And then all you need to do, once they find the right location, a small injection into it. It's a small needle, smaller than a blood test. It's usually very quick. And 1, 2, or 3 injections, depending on what the problem with the foot is, can often be quite effective. I'm going to then quickly finish on research. I've just 2 minutes. I know probably a little over time. I gave a talk recently about research and talking about why we don't have cures, and basically proving that drugs are effective for Parkinson's is very difficult. And one of the reasons is that everybody is very different, and particularly when you talk about a young onset group of people with Parkinson's, some of whom might have genetic forms of Parkinson's or might have genetic risk factors of Parkinson's, some of whom have tremor, some of whom don't. It's probably a collection of diseases. It's not one condition. As a result, lumping everybody together into a single trial often is the reason that these trials don't show benefit. It's likely that there's lots of different mechanisms happening in people's bodies that are causing Parkinson's, and trying you to test one drug to address what may be different biology for everybody is a tricky thing. The other thing is that Parkinson's may start decades before somebody's enrolled in a trial. And what we really need to do is be able to try and identify people at an earlier stage of Parkinson's, or pre-Parkinson's or prodromal Parkinson's that's known, in order to try and start drug trials then. But one of the things that I'm kind of interested in is that the way in which we measure Parkinson's disease progression is really not good. I know people are familiar with tapping fingers as a way to assess how people's Parkinson's looks, and opening and closing hands, etc. But what that is, it's a very crude scoring system. This is how clinical trials are run, that we write down a number and say that, that person's tremor is a 3, and somebody else could walk in and say it's a 2. And as a result, there's a huge variability in it. And it's a really crude way to assess things now, particularly when we have technology available. And the D&I were quite interested in using technology for Parkinson's disease. It also progresses slowly, so you really want a sensitive way to try and detect changes, and those finger tapping tests are not a good way to do it. And we could probably measure Parkinson's progression much more effectively. Particularly now, we have 2 things. One is artificial intelligence, and 2 is sensors which can track movement. And there's now evidence to suggest that Parkinson's disease could be diagnosed 7 years early just by a simple smartwatch. So we do a lot of research here at the D&I. we're interested. Some people may have even volunteered for this. I know some of you have an eye tracking study that we're finishing up now. A gait study where we use wearable sensors to try and monitor people's gait. We're interested in a particular young form of genetic Parkinson's disease called Parkin. Amy Gallagher, one of our fellows, is doing research, and I suspect she's been in touch with many of you, looking at particularly the biology of this condition, which is a little more common in Ireland than it is elsewhere. And we also look at whether people are interested in accepting technologies to monitor their Parkinson's disease. And again, people with young onset Parkinson's disease tend to be a little bit more savvy with technology and find it more useful to do. We also run the deep brain stimulation service, the national service from the Matter, and we are interested as well as in monitoring. Can we predict, using some of these quantitative measures, people who will do better from DBS than others, using gait and other speech and other sensors as well? So ultimately, the idea is that can we use lots of different types of technology, gait, eye tracking, speech, handwriting, cognitive testing, finger tapping with videos, etc., to really get a much better way of tracking Parkinson's, measuring Parkinson's, as a result being able to measure changes over time. So that's something that we're interested in doing here at the DNI, and we have a lot of other studies. I've put the research email here in case anyone's interested in any studies. We have excellent research coordinators here who coordinate all of our research. And that's it. I'm probably gone way over time, so apologies for that. But thank you for listening to me talk about it. And I don't know if there are any questions.
Thank you so much, Conor. I'm going to pop a question here in the chat, and also just give everybody else a chance to submit any questions that that they would like to share.
Great. So this first question, I don't know if everyone can see the chat. So the first question is about probiotics and the claims that it may shorten on-time medication in the context of Parkinson's disease, and whether it presents any significant risks. So there has been a lot of interest, as people probably know, in what's called a gut microbiome in Parkinson's disease, and actually brain health, this idea that the gut and the brain are connected, and that changing gut flora or gut bugs basically may have a beneficial effect on Parkinson's disease. And there's a huge amount of research, a lot of which has been led out of Ireland. I suppose there's been some research suggests that probiotics are beneficial. There have not been good, like I was talking about exercise and dystonia and those things, there have not been good randomized controlled trials. I suspect that probiotics are probably beneficial, and it might have multiple different ways of working. I also believe that treatment of constipation has a dramatic improvement in people's Parkinson's, not just because they absorb medications better, but that as you move your bowels better, you tend to move bugs and flora along as well. And there's definitely one of the reasons that the bowel might interfere with Parkinson's disease might be these bugs that are there. I don't think that there's any significant risk associated with it. As a doctor, it's very hard for me until I see research which is conducted in a certain way to prove benefit. Can I recommend that people start, for example, buying probiotics and spending their own money on it? If these were free and paid for by the government, I think the risk of it is low, and I think it's probably a reasonably low risk approach to do it. But I think the evidence isn't there yet. But there's lots of circumstantial evidence. There's lots of evidence that might support it. So I think my approach to these things, because I often get asked about new therapies that come along, and people often ask, should I be doing this? And I suppose what I say to people, if they do them and they find them beneficial, I think it's very reasonable to continue doing it because they feel that it's giving them benefit. What I tend not to do is to recommend to the next person who walks in the door to say, the last person I had in found this beneficial, so you should probably take it as well. And that may be due to the differences in people with Parkinson's disease. But until there's evidence to suggest that these things are beneficial in a clear across the board fashion, I tend not to. But I think there probably is a very still under study and probably a very beneficial way of attacking Parkinson's by modulating or changing this gut microbiome. And there's certainly been in the last 2 or 3 years huge interest in it.
Thanks so much, Conor. Fascinating. I do have one more question, if unless anybody else would Well, if you're comfortable, guys, if you'd like to maybe raise a hand to unmute yourself and ask the question, if that's easier, please feel free to do so. Um, Otherwise, I'm just going to end up hogging all the questions. And now, Conor, sorry, and I will ask you a
Fine.
question. So I did notice that there is a significant disparity in women receiving DBS surgery, although it doesn't reflect, of course, the number of women with Parkinson's who would potentially qualify. And do you have any theories around this? And do you think that this is something we need to be campaigning on or working to raise more awareness of?
Yeah, it's a great question. There's two aspects. One is that I think across the board in medicine, uh, women's health has been less well studied and less well advanced than men's health. And historically, there was a huge discrepancy in it, and particularly in Parkinson's, as you probably know, there are patient advocates out there who are very now strongly advocating for women's Parkinson's or women's health and Parkinson's to be addressed and understood in much greater fashion. So I think it's very fair to say that our understanding of sex differences in Parkinson's disease and things that we should be particularly doing for women with Parkinson's disease has not been well advanced, although I think it's probably improving. There's a separate thing. So deep brain stimulation, we see a lot of people here that matter for opinions on deep brain stimulation. And when I meet somebody young in a clinic, male or female, one of the things in the back of my mind is always going to be, is this somebody, because they're in their 40s or 50s, is this somebody that we should be thinking about deep brain stimulation for? Because there's a suggestion that maybe the earlier you do it, the better. And there's usually three responses when I bring up deep brain stimulation with people. One person will say, I love the idea of deep brain stimulation, or they come with it. They've read up on it. They say, I want this. They don't need it now. We've got, lots of different things we could do with their Parkinson's. There are people who say, maybe I might think about it down the line. And there are people who say, you're not going near my head ever in my life. Just take it off the table. And I think that one aspect of it's a big jump to go for brain surgery, and one aspect of making that leap, it's not the leap that a doctor can make for somebody. It's somebody has to say to themselves, here's the potential benefits, here are the potential risks of the surgery, and they balance those things in their head and they say, I'll either go for that or I won't. And I think, and it's probably a generalization, but I do think that men are more likely to take that risk on board than women are. And I think women, and again, this is not specific to everybody, but I think when it might explain some of the average numbers that you see, that women might just be a bit more risk averse and say, maybe I don't want an operation on my brain that has risks associated with it. I'll just, keep on managing them going on. And then men say, technology in my head, that sounds great, go for it. And to be honest with you, I think I'm probably that type of person. But I do think that it probably risk taking is part of specifically that treatment for Parkinson's. It doesn't apply to other things. And I think it might explain some of the discrepancy, but it hasn't been well studied.
There's a question there in the chat.
Oh,
I'm so sorry, but thank you very much. Very interesting and informative answer. Question there asks, what
oh
could
yeah.
reduce the locking of hands and feet at night?
Yeah. So I think I should have said is that it's sometimes difficult to answer very specific questions about a specific problem for somebody without, again, in this kind of environment. But assuming that some of the uh, locking that you're describing might be related to dystonia, sometimes, as I said, particularly if it's just a nighttime problem, having some Parkinson's medications on board at nighttime can help sometimes. So often people are taking short-acting medications during the day at 8, 12 and 8, and then go to bed at night, and then they wake up at 3 o'clock in the morning or early in the morning and their hands are locked and their feet are locked. Sometimes there's a slow release version of levodopa can work well during the night to keep the medications at it's a slowly releasing dose of medications that can keep the levodopa levels from bottoming out. As I said, if it is dystonia, botulinum toxin could be helpful for that. But it's sort of difficult to be very specific without seeing you or asking more questions and going through things. But certainly it's worth thinking about. If it's only happening at night, one, could this be dystonia? And could a little bit more medication during the nighttime help with that? The next question is, how long do the benefits of deep brain stimulation last? So, as I said about other treatments, so the important thing to say about DBS is that it is not a disease-modifying treatment. It doesn't change the course of somebody's Parkinson's disease. What it does is it improves people's symptoms of Parkinson's disease in a much more reliable fashion than medications do. So the general advice we give to people is that the benefit that you'd get from DBS is the same amount of benefit that you get from, for example, levodopa tablets. So, but what it can do is in much more reliable fashion because it happens 24 hours a day. The one thing DBS can do, which sometimes medications can't do, is improve tremors. Sometimes if people have bad tremor that's not responding to medications, that can even go away. But what it doesn't do is change the trajectory. So the one way to answer your question is to say that deep brain stimulation lasts as long as a battery lasts, because it has the potential to improve symptoms as long as that. Batteries may need to get changed every 10 or 15 years now. But what it doesn't change is what we never always know is that if somebody has DBS today, we never really know what that person is going to be like in 5 or 10 years' time, largely because we don't know what the trajectory of the Parkinson's would naturally be, and the DBS doesn't change that at all. But the symptomatic benefits last a long time. And the next question, does that answer your question? Feel free to speak up if I haven't answered your question properly, because sometimes I'm not entirely, maybe there's an underlying reason that you're asking a question I'm not addressing. So the last question then is, how do I get involved in clinical trials? So there has been a lot of talk recently about clinical trials in Ireland, and I suspect that in the coming next year or two, there may be clinical trials happening, hopefully in Ireland. There are clinical trials happening abroad, and it's sometimes tricky to take part in clinical trials outside of Ireland, largely because they tend to be very intensive. So, for example, if there's a trial in the United States, for example, there may be sort of 4 weekly visits over the course of 2 years in order to take part in the trial, and that can be very tricky to fly across. It's not impossible to do, but it can be tricky to do. But there has been, I suppose, discussions about starting some clinical trials in Ireland, and I suspect once these things are up and running, everybody will hear about it. The beauty of Ireland being small is that everyone's going to know about it before once anyone does. I'm back again. Good. Does DBS help with gait difficulties and falls? So, yes, it can. So yes, it can. Gait difficulty is one of the symptoms that are a little bit more unpredictable when it comes to deep brain stimulation. So it's reasonable to say that if someone has stiffness and slowness and tremor, which are the 3 main symptoms of Parkinson's disease, you can say with quite good confidence that those symptoms are going to improve with deep brain stimulation. Nothing's guaranteed. The one thing that's a little bit more tricky is gait. Largely because gait is a bit, once balance difficulties appear, it tends to be something that doesn't respond well to medications. And I said earlier, the effect of medications tends to mirror the effect of DBS. So if your gait is not getting better with tablets, the chance of it getting better with deep brain stimulation isn't so great. And a very small portion of people, but it's an important group of people. Sometimes people can get worsening gait difficulties after surgery, almost like as a result of the surgery. They can be difficult to address. So for that reason, when people are referred to the deep brain stimulation service here, they tend to go through fairly thorough examinations by a physiotherapist, particularly looking at people's gait to make sure that there isn't a red flag to suggest their gait might get worse after surgery. They're seen by a speech and language therapist because, again, the other thing that can sometimes worsen after deep brain stimulation, again, it's rare but can happen, is speech. So these things are assessed thoroughly. So I would say if you came to me and said, I'm starting to fall, should I get DBS to try and address that? I think that's probably not a good approach or a good way to address it. But sometimes people's gait is problematic largely because their Parkinson's isn't well controlled. And by getting Parkinson's symptoms better under control, their gait difficulties can improve. So the answer is yes and no at the same time. But I certainly think it's worth having a detailed conversation if it's something that you're interested in.
I think that's it there for the questions. If anyone does want to unmute themselves, though, if it would be easier for you to ask your question that way, please do. Otherwise, we will be wrapping up shortly. So I'll just give anyone a chance.
Can I ask a question? How many people have Parkinson's in the percentage of the population?
Good questions. So there's been we're trying to assess this in Ireland recently, and there was an audit done to try and assess it. It's actually very difficult to assess, largely because drawing these numbers from population. So we think there are probably about 15,000 people in Ireland with Parkinson's disease. Different populations have different percentages, largely because there probably is a genetic or maybe environmental component that mean it's more or less common in different parts of the world. The thing that we do know is that the incidence of it is probably increasing over time, partly due to an aging population and partly due to maybe other factors as well. So that number that sits around somewhere around 15,000 now is probably going to be maybe double in maybe 10 or 15 years time or 20 years time. So it's becoming much more common.
Conor, could I just ask you about developments in DBS? I'm conscious it's a device, it's a medical device, and technology is changing all the time. So I'm just wondering, in terms of to map forward where DBS is going, what are the sort of technological iterations that we might see in the next, in the medium term and longer term?
Yeah, great question. So this, you're right. The technology has advanced dramatically over the last few years. It's been slowly advancing over 10 years. So just to backtrack on the question, so the basic effect of deep brain stimulation has been around since the 70s, in the sense that back in the 1970s or even earlier, we knew that creating what's called a lesion, I used that term earlier on. So using a small little wire and burning a hole in a deep part of somebody's brain, which was called a pallidotomy or a thalamotomy, depending on where in the brain it was done, was really effective for managing Parkinson's symptoms. And that was the mainstay of surgery for years, until somebody realized that actually, if you leave the wire in and you pass an electrical current through that wire, for some reason, it tends to create an added benefit, and a benefit in a way that we can control where the electricity goes, so that we can get the best benefit and reduce side effects as much as possible. So that's where DBS was invented from. Then technology advanced to the point that we could stick a wire in and direct where it goes. We'd actually change the direction, so we could stimulate different parts of the brain and even send one bit of electricity that way, another bit of electricity that way, what is called steering. And that was the big development maybe 15 years ago, and allowed us to, again, control side effects much more effectively and maybe improve people's symptoms as best they can. But still, the main effect of it is actually the creation of the little hole that's caused by the wire. The big development that's happened over the last few years, and it's probably the biggest advancement that's happened in deep brain stimulation since it started, is that somebody very clever figured out that you could put the electrode in and you could record the electricity from that person's brain. And we know that depending on how much or how fast the electricity is in that part of the brain, can correlate with people's symptoms. So, for example, when these things called beta frequencies, when they go very high, that correlates with people's Parkinson's symptoms getting worse. And when they drop, they go up again. So now what we are in a situation is saying that we can actually record people's brain waves. And now we could actually set the settings of the deep brain stimulator to actually adapt or respond to the natural fluctuations that everybody gets with Parkinson's throughout the day. And so this term adaptive DBS has now been around for quite a while, but it's really reached a critical mass in that now most people who are getting surgeries now are getting the technology in their battery, which can allow adaptive deep brain stimulation to happen. It's not optimized by any means yet, and it's going to start improving over the next year or two. But the real thing now is going to be that throughout a 24-hour period, your deep brain stimulator could respond to your brain state and adjust itself over time. So if people feel they get a dip in the evening, you might find that the stimulator goes up. If you need less overnight, it might go down. And I think we're going to see huge changes in that. So it's a big technology change over time. And it's
So
going to
just
be.
just to clarify, so that's the device actually self-calibrating rather than a medical practitioner setting it.
Yeah, so where the technology is at the moment is that the way it works is it sort of switches on, it goes up and down a level basically and says, right, let's go 7 and 3, 7 and 3. So we go up and down. It doesn't track it in the most in the way I just described it, but that technology will be there very soon, and I'd be surprised if it's not going to be there in the next year or two. But yeah, so it's not somebody adjusting somebody's settings. It's basically the device itself reading the brainwaves and setting it based on those brainwaves, which correlate very well with people's symptoms.
Very good. Thank you.
No problem. Sorry, now, it says genetics. Should my children get tested, okay, to enable early detection, or is that fear-mongering? Again, a very good question. The quick and short answer is that it's probably fear-mongering. So the reason that I say that is that the genetics of Parkinson's disease is very, again, I'm going to couch this by saying it's very hard to answer a question about somebody. So if somebody is detected as having a gene which causes Parkinson's disease in a way that can be passed down from generation to generation, that's where genetic counselors should be involved, and you could talk about screening people. The general advice is that if somebody doesn't have symptoms for a condition that we can't change the course of now, whether we should be testing somebody at all, because is it of any use to somebody's child to know that they may have a genetic risk factor for Parkinson's disease if that may not definitely cause Parkinson's disease, and if we can't do anything to stop or slow the condition now. The more complicated aspect of this is that it's not as easy as saying you have a gene which causes Parkinson's disease. Some people do, and it's quite rare. Most people have genes which just increase their lifetime risk of having Parkinson's disease. It doesn't mean they'll definitely get Parkinson's disease, but these genetic, it's almost like I sort of say it's almost a little like a deck of cards. The hand of cards that you were dealt when you were conceived created a genetic lifetime risk of developing Parkinson's disease, and maybe other things like environmental factors were the reason that somebody got it at 58 instead of getting it at 78, or getting it during their lifetime or not. So it's not as simple as saying, I have Parkinson's, should my children get tested? There's a lot of ifs and ifs along that. And I'd say the only situation in which that conversation would really be happening is if you are known to have a gene that causes Parkinson's disease, and that the risk of that gene being passed to your child causing Parkinson's being very high, because it's not the case for many genes of Parkinson's disease. I went in a roundabout fashion to answer that question, but
Conor, thank you. That was a really good presentation, and that was actually one of my questions. What you just answered it there on the genetics, and particularly because I think if you've been told that some people have been told that they're presented somebody who is likely to carry the gene, should have that it would be the norm that the doctor or consultant, whoever, would then inform them about the genetic testing or how to go about it or where to go for it, because it's a worry for people and they don't know the system and they don't understand how it works. So maybe it's something we need to think about.
Yeah, so I think we do a lot of genetic testing here at the Mater, largely because we think it might be helpful in sometimes in predicting people's course if we know that they might have a gene. The vast majority of people, even if they are young developing Parkinson's, do not have a gene or do not have a known gene that causes Parkinson's disease. This is evolving all the time. And it's a little more complex than just doing a test and saying a yay or a nay. Sometimes there's in-betweeny results that don't add up, but might increase people's risk and might be the reason, as I said, that people develop it at a younger age. But certainly, I think if you wanted to get tested, and it's very reasonable to ask, could you get tested for genetic forms of Parkinson's disease? But Parkinson's is common, is one of the problems, and having a family member with Parkinson's disease is just part of
Yes.
life, and most people will have a relative who has Parkinson's, and it's so common that it's hard to say just because you've got a relative that you should be tested for a genetic form. But certainly, if you're young, it's reasonable to consider it.
Another question I have as well is around technology and the advancing of technology in DBS. I have the pump. I have the Pro Duodopa pump. And for anyone who hasn't seen it, it's like one of those old brick phones that they had back in the 1990s, and it's very unwieldy. It doesn't record anything. You have to write everything down yourself. So we're way behind in the technology on the pump. It may be moving on the DBS, but in the pump it's not. And the other thing then is around patient participation. Is around, if this is a new technology in Ireland, there's only 30 odd people who are going to have this. Surely there should be some kind of a feedback forum as to how it's working, what works, what doesn't work, because it is new, and therefore, at this stage we can develop it and we can adjust it rather than going on for the next 5 or 6 years with it not doing what it could do. When you look at what the insulin pumps do for people with diabetes, my nephew has one, and my sister knows when he has a hypo, because it goes to her phone. So the technology is, as you said, technology is there. So question.
Yeah,
Thank you.
the insulin pump, it's very similar kind of so the insulin pumps are very good because actually you can measure sugar levels very easily, and sugar levels very well correlate with how somebody's diabetes is controlled. For decades, people have been trying to measure levodopa, like dopamine levels or other chemicals related to dopamine in people's blood, to say, can we find a blood marker of where people's Parkinson's is, and that hasn't reached the point of what it could be. We just don't know. We just don't understand why we don't have a blood marker of Parkinson's at the moment. So that's the reason we can't do the feedback. For the pump therapies, we have a lot of people on pump therapies. The company themselves are very good at actually recording a lot of this data. So the nurses that come at you, it's very good to feed back to those nurses because they're collecting all of that data essentially. We send them back to them ourselves when we hear back from patients, but the direct route through nurses to the company, and that then gets pooled in the global company which are collecting this, because it is a new drug and it is a new treatment and we are learning about it. So I think it's important, as you said, that your voice is heard and your experience is heard, and we're collecting information that ourselves for our own information and presenting that at the main Irish Neurology Conference next month, actually, our experience of it.
Good to know. Thanks very much, Conor. Thank you.
Thanks.
Just one more there in the chat, if you have the time, Conor.
Yeah, I do. So, but do any treatment options for Parkinson's have an impact on postural hypertension commonly seen? Yes. So, yeah, I think the question you're asking me is, do Parkinson's medications impact postural hypertension, or whether there are treatments for postural hypertension? I'll answer both those questions. So first of all, postural hypertension is a common symptom of Parkinson's disease. It's caused by the Parkinsons. When anyone goes from lying to standing up or sitting to standing up, gravity makes everyone's blood pool in their feet. And people without Parkinson's disease have a very good response, that their blood vessels just tighten up and keep that blood up in the top half of their body so that their brain stays perfused and they don't feel lightheaded. That reflex is lost a little in Parkinson's disease, and it can be a bit sluggish. It can take even a few minutes for that tightening to happen so the blood gets back up. Medications for Parkinson's can worsen that phenomenon. And one of the classic ones that does it is actually levodopa. It doesn't happen to everybody, but you can find that as the medication dose of levodopa goes up, that the blood pressure effect, that dropping blood pressure effect, gets worse. So the medications, even though they're helping the Parkinson's symptoms, can worsen that one Parkinson's symptom. The good news is, I suppose, is that there's a whole group of medications, but they are extra medications, totally separate, that can be added on in order to keep the blood pressure up a little bit. Some of them, everyone doesn't want their blood pressure to go too high, but once your blood pressure is going up, everyone's blood pressure goes up and down. But once your blood pressure is going up and down, low blood pressure can be as much risk as high blood pressure. Sometimes you're actually trying to keep the blood pressure up a little bit higher in order to stop the dipping happening. And we can usually, with various forms of medications, control that quite well. The other thing to say is that keeping well hydrated, taking regular salt is very important. The other things which nobody likes doing is wearing things like compression stockings, which are awful and very uncomfortable, and nobody likes wearing them, but they can sometimes keep the blood up in the top half of your body. There are things like corsets, like called abdominal binders, that can keep the blood up. This is without taking medications at all. And the other thing is that people often find that they can get lighted after a meal because your blood goes to your stomach to digest your food. Sometimes a big lunch is a big thing. So sometimes drinking lots of water during your meal, not having big, large meals, and taking your time getting up after a meal is sometimes the best way to address it. Great. The message fall due to used to fall due to freezing. Still happens, but now it's also falling kind of crumbling way, maybe due to leg weakness. Yeah, so obviously freezing is very common. It's very problematic. I don't know how to specifically answer that question without talking to you more or examining you. I mean, there's lots of things that can cause legs to give way, including back problems. You know, one of the problems with having Parkinson's disease is sometimes everything gets blamed on the Parkinsons, and sometimes it's worthwhile trying to see what else is going on, because things like back problems are problematic. If the legs are giving way, it's worthwhile thinking, could it be something else? People do feel sometimes that legs give way with Parkinson's disease, and it can be sometimes a symptom of Parkinson's being, you know, less well controlled. Freezing of gait is a difficult thing to manage in and of itself. We don't have good treatments or medications for it. But I'm not sure I can answer that question directly and specifically, but certainly it's worthwhile thinking about whether there may be something else that's driving it, particularly if it's a new problem that's come on. When you're saying that there's a freezing in the past and now there's falling with legs going away, it's certainly sometimes worth addressing it, but it might be worth being seen about that, specifically asking about that problem, because it's not an easy one to answer blindly, if I can use that term.
Thank you so much, Conor, for your time, because I know that we've kept you a good 20 minutes longer. So I really appreciate that. Thank you, everybody, for joining us. And I will be sharing the recording as soon as it's ready, and we'll be putting it online so that everyone can benefit from all those brilliant insights you've given us. So thanks again, Conor, and thank you, everyone, for joining.
Thanks, everybody. Thanks for all the questions, and thanks, Brittany. Thanks, Joe.